What's up, Ninja Nerds? In this video today, we're going to be talking about prostate disorders. Again, this is part of our clinical medicine section. If you guys like these videos, they help you, they make sense, please support us. Some of the simple ways that you can do that is by hitting the like button, commenting down in the comment section, and please subscribe. Also, for your benefit, I really urge you guys, go down in the description box below. There's a link to our website. If you guys become a member, you'll have access to thousands of notes, illustrations, quiz questions, and even if you guys are preparing for some board exams, PANCE, and your NCLEX, your USMLE Step 1, Step 2, we're going to have all of those ready to go soon. All right, so let's talk a little bit about prostate disorders. So when we talk about these, there's two different types, if you will. One is called BPH. We also refer to it as benign prostatic hyperplasia. In this disorder, it's actually pretty straightforward. In these patients, they have a very enlarged prostate. There's a lot of hyperplasia, lots of enlargement of the prostate gland. And what happens is, the big thing here is it compresses on the prostatic urethra. All right, so that's the big key thing here, is that there is some type of prostate hyperplasia. Now, oftentimes for your step one, they'll talk about like the particular location of where this is actually occurring. It is kind of important to know. I like to know it's the transition zone or the periurethral zone is the particular location of where it'll actually be the most pronounced enlargement. But either way, this prostatic hyperplasia that we see right here is leading to compression. Right, so it's compressing the actual prostatic urethra. So from here we get compression of the urethra, and then you kind of obstruct as a result here the bladder outlet obstruction. And so what ends up happening as a result of this is that you end up causing a retention of urine. So what happens is you end up with urine retention. And that urine retention can lead to many different complications. One is it can lead to overflow incontinence. The other one is it could lead to a urinary tract obstruction that leads to a postrenal AKI. And sometimes it can even lead to urinary tract infections as well. But we have to start asking ourselves the question, okay, we know there's a lot of prostate hyperplasia, and just for the fullness sake here, we talked that it's usually in two particular areas. One is the transition zone, that's oftentimes the most common one, or the periurethral zone. And again, it's just leading to, as there's hyperplasia in those zones, compression of the urethra. And then as a result, retention, and that's the problem that we see here. We'll talk about some of the symptoms that we'll refer to a little bit later. But the question I want you guys to start asking yourself is, what's causing the prostate hyperplasia? Well, oftentimes it's a very specific hormone. It's called DHT, dihydrotestosterone. So if you guys remember, there is a hormone that our body makes. It's called testosterone. And testosterone, what happens is it is converted into DHT. Now it's converted via an enzyme. This enzyme is called 5-alpha reductase. I actually think it's really important to remember this, because later, this is important is there's actually drugs that can target that particular enzyme. But this enzyme is easily converted, and there's an increased conversion. This process is more escalated, which leads to an increase in the formation of DHT. The problem is that DHT, when in the prostate gland, it really accelerates prostate hyperplasia. So then you have to ask yourselves the question, what's causing this? And oftentimes the triggers for this increased DHT is just as we age. And that's the sad part, that as patients usually get above the age of 40, so greater than the age of 40, we start to see this particular change. That is really the biggest thing, is really increasing age. And then as a result, increasing DHT levels usually follow suit. Now there could be other things. Sometimes people have increasing DHT as well through certain diseases, but oftentimes it's usually related to increasing age. But let's just put here, just so we remember, it also could be due to increased DHT. Now, that is the biggest thing here. So as patients get a little bit older, greater than the age of 40, they start having increased prostate hyperplasia. What's the problem with that? Why is that such a bad thing? We already talked about it can lead to urine retention. Now, one of the things here is that whenever urine is retained inside of the bladder, one thing that can happen is it can actually increase your detrusor activity, or it can at least irritate it a lot. Increase detrusor irritability. Let's use that term. I like that better. As you increase your detrusor irritability, the detrusor muscle starts kind of like pounding down and kind of gets a little bit irritable and tries to cause contraction. Problem is that you got this big old honking donut that's blocking urine outflow. And so what happens is these patients, their bladder's contracting and it's generating the sensation that they have to go really bad. And so oftentimes they'll present with urgency and frequency. And that's oftentimes one of the biggest things is they'll have urgency and frequency. That'll start to increase. They'll have to go to the bathroom very, very quickly and very frequently because of the gallbladder, because of the bladder contractions. The other thing is that the urine retains. It actually can lead to problems where sometimes the bladder starts actually getting really, really big and over distended. So we can also have urine retention that leads to a very enlarged bladder. So let's put here that it causes intense bladder distension. But the problem is that you have such a large bladder, it's really, really distending. And so urine is accumulating and accumulating inside of this bladder. The problem is that the prostate is blocking the outflow. The issue with this is that these patients have hesitancy. They feel like it's really hard to be able to go to the bathroom, and when they do, their stream is very weak. So because of this, oftentimes these patients, when they're trying to go to the bathroom, they have this obstruction because of the large bladder. And so what happens is they have hesitancy and then oftentimes a very weak stream because they're really trying to squeeze urine through this tiny little prostatic urethra. So hesitancy and a weak stream. Sometimes we even say dribbling. They'll have lots of dribbling associated with this. When these patients come, they'll say, man, I really feel like I have to go to the bathroom a lot, really quickly, very frequently. When I try to go, I can't really go. And when I do, I just dribble. That's oftentimes the classic presentation for these patients. In comparison to these prostatitis disorders, which we'll talk about, the prostate gland is enlarged, but it's usually relatively symmetric. It's not very tender, it's not very painful, and that's one of the big differences because we'll talk about something called the digital rectal exam, and that's usually another way that we can add on to the diagnosis of BPH. Usually age, symptomatology, and the DRE that supports a normal enlarged prostate. With that being said, let's move into the next category of prostate disorders called prostatitis. This is inflammation of the prostate gland. There's two particular phenotypes. One is there is an acute type of prostatitis and a chronic prostatitis. Chronic prostatitis is actually very difficult to diagnose. With acute prostatitis, it's a little bit easier. It can actually kind of both of them can sound like UTIs, to be honest with you. But there is a couple subtle differences. So within these prostatitis, there is different etiologies. I'd say for acute prostatitis, the most common etiology is going to be infection, bacterial infection specifically. So there's going to be some type of infection that triggers massive prostate inflammation. And that prostate inflammation, as a result, my friends, will lead to compression of the prostatic urethra. And as it does that, it may lead to some degree of urine retention. Okay? So what we'll see from this is that the patient will have an infection that'll stimulate prostate inflammation, that'll cause compression of the prostatic urethra, and may lead to some degree of urine retention. The question that arises here is that what is actually the trigger for these infections? And there is a couple different types. So here's what I want you to remember. If the patient is less than 35 years of age, the most common cause is usually gonorrhea or chlamydia. All right, so they got that nasty stuff there, and what happens is these are usually a sexually transmitted infection. So the reason why we say less than 35 years of age is there's probably some degree of unprotected sex that maybe is involved, maybe it's stereotypical, but there is a suggestion that there's a STI or a sexually transmitted infection that may be involved here. That could trigger the infection. If they are greater than 35, then it's likely E. coli. And E. coli, you have to remember, is a part of our normal urogenitary tract, and so sometimes it's definitely possible for that bacteria, if it's in the vicinity, to cause an infection, especially if there's overpopulation. Now, with that being said, if you have Greater than 35, E. coli may be the trigger for that infection that causes the prostate inflammation. So what about chronic? It's the same exact thing actually. So you'll still get prostate inflammation here. You're still going to get prostate inflammation. You'll still get some degree of compression. So there may be some degree of compression, let's actually bring it like right here, of the urethra. It's not as intense as an acute state, but it is present. So there will be compression. And this will again lead to maybe some degree of urine retention. And that urine retention may stimulate an increase in detrusor irritability, as we talked about before. And with that increase in detrusor irritability comes this presentation that we talked about called storage LUTS, or storage lower urinary tract symptoms, right? And what happened here is that we said that the actual bladder was contracting down. It had an increased intensity of contraction. But you have this prostate that's some degree of inflamed, and it is kind of compressing the prostatic urethra and obstructing the flow a little bit. So because of that, it's contracting, but you may have a difficult time getting the urine out. And so because of this, they will present with urgency, same thing as before, and frequency. But here's the other thing that you want to add on. They're also causing inflammation. So there's inflammation of this puppy here, this donut around your prostate, your prostatic urethra. And whenever that's involved, it's a part of your prostatic tissue, the urethral tissue. And if that's inflamed, it can cause burning whenever urine is moving through. And so that's oftentimes referred to as dysuria. So that's one big thing. You oftentimes won't see that in a patient who has BPH. So dysuria is a very important one to remember. And that can be present in both acute and chronic. Now, BPH had voiding LUTS, which means that they had hesitancy and a weak stream, plus they had urgency and frequency. This one doesn't have the voiding LUTS, the hesitancy, the weak stream type of process. Well, what else helps? With acute prostatitis, this infection oftentimes is usually going to be primarily, again, gonorrhea, chlamydia, E. coli. With chronic, it's just E. coli, only E. coli. That's all that you'll ever get here. With acute prostatitis, when you have this infection, this patient population for an acute will have an infection that triggers a systemic inflammatory response. So they will have an increase in white blood cell count. They'll have a fever, and they'll have a very, very angry and inflamed prostate that it'll cause so much pain around this area, usually in the pelvic or perianal region. So because of that, you'll have three particular things that will separate it from chronic. One is a high fever, an increased white blood cell count, and an increase in that pelvic pain area. So increased fever, white blood cell count, so a leukocytosis, and pelvic pain, usually around the perianal area. For chronic, on the other hand, which is only due to E. coli, this one will have no fever, no white blood cell count, but it will have some degree of pelvic pain. So that's the thing, no fever, no white blood cell count, but it will have pelvic pain. So how do we kind of also add to the tail here? So we know that they both can have storage LUTS. This one will have more of a systemic inflammatory response. This one will not have that. This one's only due to E. coli. This one is due to either of these, just depends on the age range. Well, the other thing is that with this one, it will be inflamed, but it's not going to be as inflamed where it's going to cause that degree of pelvic pain. The other thing here is, because this thing is super angry, it'll be very tender if palpated, extremely tender on DRE, on the digital rectal exam. This one, it will not be tender or boggy-like on the digital rectal exam. And I think that really adds to the diagnostic utility in this disease, okay? Chronic prostatitis is sometimes even difficult to differentiate from what's called chronic pelvic pain syndrome. It is a difficult diagnosis. These patients can have infections. They also can have storage LUTS. And sometimes patients with acute prostatitis in a perfect world, where they will not always present with a fever and a leukocytosis. So it can be difficult, but in a perfect world for your exams, usually acute, associated with fever, leukocytosis, and a very tender prostate on DRE. Chronic, not tender, no fever, no leukocytosis, but both of them can present with pelvic pain and storage LUTs. Okay, my friends, so that kind of covers our pathophysiology, the causes, the clinical findings. Now let's talk about some of the complications. All right, my friends, so at this point, we've talked about how the prostate's as big as a peach, right, at this point, that you have prostatic hyperplasia or you have prostatitis. That thing is gargantuous and it's just mashing on the bladder outlet or near the prostatic urethra, and it's obstructing the flow of urine. We talked about a lot of the LUTs kind of symptoms, the lower urinary tract symptoms that they have, the storage LUTs, the voiding LUTs, particularly with BPH, and then the storage LUTs, particularly with the prostatitis symptoms. Now, when a patient comes in and they have any of these prostate disorders, they can experience complications. Some of these complications that can arise is a urinary tract obstruction that can cause post-renal acute kidney injury, believe it or not. What happens here is that, let's say that you have an enlarged prostate, right? Whether this is BPH or I would say more likely acute prostatitis, it is kind of unlikely that chronic prostatitis will cause this degree of kind of compression of the urethra. But in these particular disorders, you may see compression of the urethra. Now, from the compression of the urethra or bladder outlet obstruction, you'll see that factor that we've talked about pretty consistently here, is that with this will come the inability for urine to flow outwards. As a result, urine will build up. So at this point, you'll have an inhibition of consistent urine flow, and urine will build up inside of the bladder and trigger bladder distension. So with that comes an increase in urine retention. And with urine retention comes bladder distension and pressure. So there'll be an increase in bladder distension, and then as a result, the pressure in the bladder will go up. So at this point, BPH will stimulate compression of the urethra, lead to urine retention, lead to increased bladder distension, and as a result, an increase in bladder pressure. Now at this point, what happens is if the pressure in the bladder is so high, it could start kind of flowing backwards into the ureter, up into the kidney, and then start causing fluid or urine to accumulate inside of the kidney. Now, with this being said, this is what we refer to as hydronephrosis. So this can cause retrograde flow, which we talked about. And from that retrograde flow, you'll lead to the enlargement of the ureter and the kidneys. And this can be called hydronephrosis. So you're going to kind of like fluid, like waterlog, if you want to think about this, the kidney. Now, as a result, whenever a patient has a lot of pressure building up, what can happen is this kidney will enlarge, maybe even the ureter will start to become a little bit more dilated, and then we already know that the patient's bladder can also be enlarged and distended. When we see this, this can be very evident on a renal ultrasound. You'd be able to see the enlargement of the kidney, you'd be able to see the enlargement of the ureter, and then exclude that there's not any kind of stone that's causing this. And then you'd come down to the bladder, do a bladder ultrasound and say, oh my gosh, the thing's the size of a watermelon. So there's obviously bladder distension because of a bladder outlet obstruction in this particular scenario. Now, another problem with hydronephrosis is, yes, it can cause like maybe flank pain, but the other concept here is that it could actually acutely drop the GFR from the kidneys because you're going to increase your renal capsule pressure. And what happens is when that capsular hydrostatic pressure goes up, your filtration pressure goes down. And this can lead to a post-renal AKI. So an acute kidney injury, my friends. Now, how would this present? Well, this can present in a couple different ways. One is the creatinine, the BUN can start going up and the urine output could decrease. So you want to look as the patient have an increase in BUN, increase in creatinine, and their urine output is really slowed down. In combination with evidence of hydronephrosis, and if you did do a bladder ultrasound, you would see also distension of the bladder as well, due to a bladder outlet obstruction, such as in BPH or acute prostatitis. Okay, that gives us the concept here that I would really want you guys to know for urinary tract obstruction. Again, you'd really only see this one with BPH or acute prostatitis. With that being said, we now say there's another complication that can arise, a urinary tract infection. It's the same thing. It's unlikely that you'll see this in acute prostatitis. You're more likely to see this in like very severe BPH or acute prostatitis. And the concept behind this is relatively the same. That in these two diseases, there is either a very acute enlargement of the prostate or a very progressive enlargement of the prostate to the point where it has caused significant, look at that thing, ain't nothing getting through there, a massive compression of the bladder outlet or the urethra. So now there's massive compression of the urethra. No flow is getting out of that dang bladder, right? There's not a dang thing that's going to get out through this. So the urine will continue to accumulate as a result. So this process will be inhibited. Now, with increasing compression comes increasing in urine retention, and then comes increase in bacterial colonization. So let's write this down. So with compression, increases urine retention. When you retain urine, especially over a long period of time, bacteria can build up, and we call this bacterial colonization. Now, this may not be a bad thing, but if the bacteria are present in very large amounts, they can cause infection and inflammation. With that high risk of infection becomes a very significant problem, because now I have tons of bacteria sitting in the urine of my bladder, and this can definitely lead to features of what we call cystitis. So in other words, it can start infecting the bladder tissue. All right, and this can cause inflammation of the bladder tissue. We call this cystitis. So that's one presentation. The other thing is that this kind of bacteria can also move retrograde through the ureter up into the kidney and cause an infection of the kidney. When you cause an infection of the kidney, this is actually pretty bad. This is referred to as pyelonephritis. This is kind of the combination of urinary tract infections, if you want to think about them. And oftentimes with these patients, they'll have a lot of symptoms of urinary frequency, urgency, dysuria. So oftentimes they have a very classic presentation that may be kind of difficult when you think about it to suss out from some of these other disorders like acute prostatitis. So you'll think about it, you'll be like, wait a second, is this really that? Because what will happen is they'll present with urgency, frequency, and then they'll also present with dysuria. The other thing is that you'll obtain a urinalysis, and it'll be heavily positive for a urinary tract infection. Oftentimes, and we'll talk about this, when you're testing for acute prostatitis, the preferred test is you actually have to go in and push on the prostate. So you have to go up digital rectal exam and massage the prostate and have them urinate afterwards so that some of that prostatic fluid can get released into the urethra, carried out into the urine sample. And so you can find, oh, there's large amounts of E. coli or gonorrhea or chlamydia. But oftentimes these are ways that we can definitely help to think, could the patient also have a urinary tract infection secondary to the acute prostatitis or secondary to BPH? It may be kind of difficult at times to suss out acute prostatitis from a urinary tract infection, but it will be easy to suss it out from BPH. Okay, we come to the last one, a prostate abscess. A prostate abscess is very, very common in acute prostatitis. So when a patient has acute prostatitis, the problem that usually arises here is that they have a very significant inflammation, prostatitis. What happens with this one is it causes an acute infection, and this infection will cause just primary involvement of the prostate gland, right? This prostate gland will get crazy inflamed, and we talked, you can get fevers, you can get leukocytosis, you can get pelvic pain, urgency, frequency, dysuria, and we talked about a lot of those particular symptoms are very specific to, again, acute prostatitis. What happens is that sometimes the infection can kind of wall off. So it can become kind of encapsulated. and you can cause this really, really nasty abscess to start to form. Now, the problem with this is that sometimes it can be relatively difficult to suss out between acute prostatitis. When this is present, usually the patient may be getting treated for acute prostatitis and it doesn't get better. And so usually there is the persistence of fever, there's the persistence of an acute leukocytosis, and there is worsening pelvic pain to the point where they can't even sit down. So when they have this prostate abscess, one of the things that you have to assess for is, are they getting treated? Is their fever getting better? Is their white blood cell count getting better? Is their pelvic pain getting any better? If it is getting worse, this is very concerning for a prostate abscess. Oftentimes, to make this diagnosis, again, you may assess the patient for acute prostatitis. You'll go in and do a DRE. Maybe you'll feel something a little bit weird, but oftentimes what we have to do is we have to do something called a transrectal ultrasound. So we usually do what's called a transrectal ultrasound. And that will usually be positive, and it'll show, oh, there's this area inside or around the prostate that is very anechoic or hypoechoic, and it looks like there's a fluid-filled cavity there, and definitely lots of inflammation and fat stranding around that area. That would definitely be suggestive of a prostate abscess. But again, really think about this. If a patient has acute prostatitis, they're on antibiotics, and they're usually on it for like 6 weeks. If they're not getting better, there's worsening fever, worsening leukocytosis, or at least it's persistent, and the pain is getting much worse, you really want to go ahead and do a transrectal ultrasound and rule out a prostate abscess. All right, my friends, that covers a patient who has a prostate disorder. What are the complications that can arise? Now that we've done that, let's now move into the diagnostic approach. All right, how do we diagnose all these prostate disorders? Well, BPH, we'll start with this one kind of first. In patients who you suspect have BPH, they'll present with the classic symptoms that we talked about, the storage LUTS and the voiding LUTS. So storage LUTS is the urgency, frequency, nocturia. Voiding LUTS is they'll present with the hesitancy, weak stream, and maybe dribbling and straining during urination. So the first thing I want to know is this potentially like cancer? Because one of the things is BPH, whenever you have a lot of prostate tissue, they can release this thing called prostate-specific antigen. And if it's really, really elevated, it could suggest prostate cancer, but it also could suggest BPH. And so the only difference to delineate these two is both the combination of a PSA and a DRE. Because if a PSA is greater than 4, it could be indicative of BPH, but the only way that I can guarantee that is if I stick my finger up there and I palpate and I feel no irregularities, I feel no like super hard mass on one side of the prostate gland. It just in general, it appears enlarged, rubbery, and firm, but it doesn't feel like there's an obvious mass present. In that scenario, then I can be suspicious that it's likely BPH. The other thing here is prostatitis. Now we kind of get into a little bit more of a rut here because it's a little bit more difficult. Acute prostatitis is actually somewhat easy to diagnose in the sense that you should obtain a CBC to look for a leukocytosis. You should get a UA with a urine culture. Here's the tough thing. You're trying to get the bacteria out of the prostate gland. Because if I get a UA and it comes up positive for pathogens, or I see like, oh, they have a very high white cell count, they have bacteria in their urine, they have leukocyte esterase and nitrates, I could just think that it's a urinary tract infection. I want to squeeze like a jelly donut some of the bacteria out of the prostate gland and into the actual urethra so I can collect that sample. And so oftentimes we may do that. However, there is this concern in the world that if we push on the prostate, we could squeeze pathogens into the bloodstream and precipitate sepsis. So you really shouldn't be doing this in a person that you suspect has acute prostatitis. That's why you have to have a high degree of suspicion for this. But if you start off and your white blood cells elevated, you got a fever, you got pelvic pain, the DRE suggests that it's very tender and it's boggy appearing, your urinalysis and urine culture come up positive, you can suspect that it's likely acute prostatitis. But again, the prostate massage would be the best way to assure that it's bacteria from the prostate gland rather than not in the urinary tract itself. The other thing to remember is that patients with acute prostatitis, if they present with worsening fevers, they present with worsening pelvic pain and worsening LUTS, I would really take the time to consider working them up for a prostate abscess. And one of the best ways to do that is to do what's called a transrectal ultrasound. And so you'll take an ultrasound, you'll unfortunately put it up the rectum and look in the area of the prostate. And so here we can see that there's this definitely heterogeneous appearance of the actual prostate gland. And this suggests that there's definitely an abscess there that's sitting. And that would be important for diagnosing a prostate abscess. For chronic prostatitis, this is not an easy diagnosis. It's relatively difficult to discern. And usually sometimes people even kind of put this into the area of like chronic like pelvic pain syndrome sometimes. But what happens with this one is that usually their white blood cell count won't be elevated. It usually sometimes be normal. Their urinalysis and urine culture can be variable. Sometimes it can be positive, sometimes it can be negative. Oftentimes with this one, it is best to do the prostate massage. So usually for these patients, we can do a DRE as we're doing the DRE, and it feels kind of like boggy. It feels enlarged, but it's not super tender. While you're there, sometimes it might be best to squeeze onto the prostate and obtain a sample of a urinalysis afterwards. And so we can do that via like the 4-glass test. So as you're doing the prostate massage, you may have them collect urine before you do it. You may have them collect it like during the process of while you're squeezing it, and then afterwards. And then you're basically looking at the results of that 4-glass test to see if there is any bacteria like E. coli present. But this one's, again, pretty tough to diagnose. Now, in a patient who has prostate disorder such as BPH, it's a lot of different treatments that can go into this. I think one of the big things to remember here is that oftentimes we're trying to decrease the obstruction of the bladder outlet so that they can help to be able to eliminate their bladder. They're not developing lower urinary tract symptoms. And so that's the biggest thing. We also want them to develop complications such as, post-renal AKI or urinary tract infections. So how do we do this? One way is we can apply medical therapy to try to reduce the symptoms, to improve the symptoms. And so oftentimes we'll give something called alpha-1 blockers. This is things like tamsulosin, doxazosin, prazosin, terazosin. And what they're going to do is they're going to act on the alpha-1 receptor and then inhibit it. When they do that, it's then going to allow for them to relax the area here and open up the bladder outlet a little bit so that they can allow for urine to continue to flow. All right, so that will definitely help with reducing the bladder outlet obstruction. An alternative is going to be considered in patients who are on 5-alpha reductase inhibitors. So this is kind of going back to that mechanism that in patients who have, testosterone, what happens? Well, testosterone, again, is going to be acted on by the 5-alpha reductase, and that converts testosterone into DHT. And the DHT is what triggers a lot of the hyperplasia and enlargement of the prostate gland. What if I give drugs like finasteride and deutericide, which inhibit the 5-alpha reductase, which then don't allow for testosterone to be converted into DHT, so DHT levels will be lower, and therefore I will reduce the hyperplasia and enlargement of the prostate gland. Great. Well, how do I know which one to put them on? Right? There's a lot of different ways that we can look at it. Oftentimes it's kind of straightforward. If the prostate's pretty big and their PSI is high, and you want to try to shrink the size of it, the best thing is going to be the 5-alpha reductase inhibitors, because that's what you're going to be doing, is trying to shrink the size of it. If you're looking more for just like symptom control and more mild, moderate size prostate, so they don't have a super large elevation in their PSA, and you want to try to improve symptoms, then that's where alpha-1 blockers come into play. Oftentimes you can combine them. There's lots of times where you put them on an alpha-1 blocker to improve their symptoms. They're not really getting it better. Their prostate's still starting to enlarge. Their PSA is rising. They're already on an alpha-1 blocker. You add on a 5-alpha reductase inhibitor, and they're still having symptoms despite all of that combination therapy. Then you go to the next thing, which is consulting a urology person for a TURP procedure. And so this is a transurethral resection of the prostate gland, where you'll actually go up through the prostate, resect out parts of the actual prostate gland that are impeding on the prostatic urethra and the bladder outlet, open that area up so that you can restore good urine flow. All right, so that's going to help to remove a lot of that excess prostatic tissue. Now, acute prostatitis is an infection. You got to clear the infection. If they got the gonorrheas and the chlamydias, then you got to treat them appropriately. Usually ceftriaxone will cover the gonorrhea and doxycycline will cover the chlamydia. For patients who have E. coli, oftentimes for these patients, you can treat them with fluoroquinolones. That's usually going to be the drug of choice like ciprofloxacin. But the big thing for acute prostatitis is they may require treatment for like 4 to 6 weeks of these antibiotics, because it's really hard to penetrate that prostate capsule. Trimethoprim sulfamethoxazole could be an alternative, but again, fluoroquinolones are going to be the first line. For patients with chronic prostatitis, again, you may put them on fluoroquinolones like ciprofloxacin for like 4 to 6 weeks. So they could be on these antibiotics for a really long time. And that's the only downside with fluoroquinolones, is because they do have a risk of tendon rupture, especially Achilles tendon rupture. So that's something to consider long term. Now, in a patient who does have chronic prostatitis, if you're trying to get rid of the chronically inflamed tissue, you've put them on antibiotics, they've been on antibiotics for 4 to 6 weeks, they're still having lower urinary tract symptoms, then you can potentially go to the area of a TURP and remove some of the chronically inflamed prostatic tissue to improve some of the lower urinary tract symptoms. But again, that would usually be like a last resort option. All right, my friends, that covers prostate disorders. I hope it made sense. I really hope that you guys did enjoy it and learned a lot. As always, thank you, love you, and until next time.